Okay, well, it is 7 o'clock now, so I think we should start because we have a lot to cover this evening. First of all, Dr. Bransfield, delighted to have you again. Thank you very much.
Thank you, Joey, and happy to be here. Thanks for inviting me.
Thank you. Well, it's just fantastic to have Dr. Bransfield back again. He was with us twice not too long ago talking about COVID in our COVID series, and now he's here today to talk about the connections between chronic Lyme disease and chronic COVID. I'll just introduce him briefly. He's a board certified psychiatrist and an associate clinical professor at Rutgers Robert Wood Johnson Medical School, and he also works in private practice. He has a particular interest in psychopharmacology, a unified theory of mental health and illness, and that's the link between microbes and mental illness. He'll be talking today about a patient cohort that he does often encounter nowadays, which is the overlap between Lyme disease and COVID. So we'll be listening to his fascinating presentation for about 45 minutes. Please do put your questions in the chat or the Q&A, and then we'll have 15 to 20 minutes at the end to ask you questions. So thank you very much, Dr. Bransfield.
Okay, thank you, Joey. Let me get my slides up here. Okay, so. Okay. Okay, so what I'm going to talk about is chronic, and I like to use that word because that's the appropriate word, chronic Lyme and chronic COVID. And let's look at both things individually and together, and how can we sort this out, because this is something we're dealing with now. And I like to think of this as the three great imitators. The first was syphilis, which was a great imitator. And then Lyme was considered the second great imitator. And now I think we're going to have COVID that's really the third great imitator. And what happens if you have more than one of these imitators at the same time? So it raised the question, how effective are we at dealing with emerging new diseases, such as Lyme disease, chronic fatigue, myalgic encephalitis, autism, fibro, Gulf War syndrome, or Jellens? And generally, we don't do a very good job, because a lot of times there's the frontline clinicians that have the long-term responsibility of dealing with these patients year after year. And then there's medical bureaucracies that are arm's length, and they often set policy while never treating a single patient. And these are often chronic, complex, costly diseases. So there's a big price tag. So there's a lot of financial issues that are the elephant in the room in the background. And when we identify the chronic symptoms, how do we identify, understand, and treat these symptoms in an effective way? One thing is when there's COVID, another thing is when there's Lyme, or when there's both, and how can we sort this out? So first, let's use definitions and identify what are we talking about. And chronic is a word. How do you define chronic? So this is a medical definition. A chronic disease is one that's lasting 3 months. And by some definition, they would say 6 months. 3 months or more by definition, and this is a statistical definition. Chronic diseases generally cannot be prevented, they say, by vaccine, but that's not always a criteria for chronic, or cured by medication, nor do they just disappear. So they're long duration, they're persistent. Persistent is another word. And the word long haulers has been used. And what's a long hauler? It's a trucker's term, someone who transports something over long distances, usually 500 miles a day. And, that has been used, but it's an improper and inappropriate term. So we need the proper nomenclature. Why use a trucker's term for a medical condition? What's a better term? Post-acute is better, but post-acute really is chronic. What's more accurate than post-acute, but chronic? Chronic is persistent. So, and then we have to look at, is it chronic infection or chronic symptoms, or both, okay? Or is it, and if it's chronic infection, is it chronic active infection causing symptoms or latent infection. So is it hit and run infection that does its damage and leaves, or is there persistent infection? And late stage is another word, just like we use with Lyme disease, late stage Lyme disease. Or post-treatment is a word, but that's a very vague term because was it effective or ineffective treatment, or was it given in a timely manner? Calling it a syndrome, we can't call it a syndrome because it's not fixed and it shows differently in different people. So post-infection, and we can't necessarily prove it's post-infection. There may be certain persistent infection in some people, and there's evidence of that in the literature. A new word is post-acute sequelae of COVID. Apparently that's something that's just come up. That's certainly better than long haulers. So then the question comes up, if there is post-infection, do antimicrobial treatments help? As we encounter with what's called post-treatment Lyme disease. So that there's people that are invested in saying there's no such thing as chronic Lyme, and some people have invested their entire careers with that belief system, and it's hard to change once a person's locked in. We know in autopsies that Borrelia is found in autopsy. That's the final, that's the absolute authority. That's the gold standard, not controlled trials with antibiotics, but autopsies. So, and we see that many Lyme patients improve from antimicrobial treatment, including disulfiram, and they get Herxheimer reactions. So we know that there is post-infection. Now, when we look at post-COVID and Lyme, and looking at both COVID and Lyme, they have acute symptoms in some, no chronic symptoms in some, mild chronic symptoms in others. It can be severe in others. It can be relapsing, remitting, or progressive, and expanding symptoms. So symptoms can get worse, and an increased number of symptoms can occur over time. Or it could be a combination of both. What if you have both Lyme and COVID, right? So when you have both, how does Lyme affect COVID, and how does COVID affect Lyme? What's the reciprocal effect? And here we're looking at the concept of complex interactive infection. I think that's a good concept. We could think of that with AIDS. We could think of it tick-borne disease. We could think of it with COVID and other infections. What is the interaction? And I think of, let's say, a fox hunt as an example. If I go wandering in the woods looking for a fox as one species alone, I would not be very successful. But if you have people, horses, and dogs, and there's that interactive effect, it has a greater impact than either infection alone. And that's something like you saw with AIDS, where a person gets AIDS and then these other infections that are latent become active. And that's a model I think we have to use. So Lyme disease, now that we have COVID, it's very easy that people are excessively focused on it. And you can miss a diagnosis of Lyme disease. And we're doing that. We're seeing a lot of medical conditions, everyone's focused on COVID, and they miss other diagnostic entities that might exist. I just dealt with that today with a patient. So this was an article pointing that out about overlooking Lyme disease and calling it COVID by mistake. So both Lyme and COVID can have post-acute, which post-acute is chronic symptoms. And once you're past that acute phase, there's this group of people that have these long-term adverse effects. And it has a lot of similarities to other post-acute viral syndromes, such as chronic fatigue, myalgic encephalitis, very similar, where you have fatigue and myalgias, depression, non-restorative sleep, that combination. So how are chronic COVID symptoms different from chronic Lyme symptoms? There's a big overlap, and I think the overlap is, in many of these cases, you have this chronic immune-provoked inflammatory condition. It's a multi-system immune-mediated group of symptoms, and they're all very similar. So like the brain fog, the fatigue, the cognitive impairments, that happens with all these conditions. But what is it that's unique to different subcategories of infections? So if we look at, let's say, COVID versus other chronic immune-provoked conditions, you do have more pulmonary symptoms and some unique pulmonary findings. Compared to Lyme, you have more myocarditis. Even though you have some with Lyme, but not as much, you have more severe post-exertional fatigue with COVID. you have more similarities to chronic fatigue, myalgic encephalitis. You also have more clots and vascular symptoms, and you have a higher percent of patients with loss of smell and loss of taste. Even though you do see that with Lyme, not as many with Lyme have that. Lyme has somewhat more cranial nerve symptoms, but we see plenty of cranial nerve symptoms also with COVID. There was a recent CEO of what was called Texas Roadhouse, and he had COVID, and he had terrible tinnitus that was so bad he committed suicide this week from distress from that. Eighth nerve, you see eighth nerve involvement with COVID. But Lyme, you also have more arthritic symptoms, although you have arthritic symptoms as COVID, but not as many. It's not as severe, so it's a bit of a shift. So when you get COVID, does it trigger a complex interactive infection? And that's the word, I think. So we see that when, let's say, someone has Lyme and then they get Epstein-Barr, and then it triggers a more severe infection, like the foxhound example I was using. We say about Lyme, Babesia, Bartonella, Anaplasma, opportunistic viruses. If it happens with other conditions, you could think it would happen with the COVID too. So the question is, does the infection with COVID sometimes activate a previously latent or simmering case of Lyme tick-borne disease in some people? That's the question to ask. Now, this is COVID. It starts with fatigue. It's a big thing, but look at all the other symptoms that when we expand and intensify the symptoms, we get a little bit of everything. And when you look at all the symptoms that have been reported, there have actually been hundreds with different studies. Although a lot of times people focus on what are the most dominant symptoms, the more common symptoms, but there's always someone who has some unique presentation, just like with Lyme. And another problem that we see with COVID, which is SARS-CoV-2, which is the infection, is that the RNA can be incorporated into the human genome. So that's a problem, and it can lay the groundwork for possible autoimmune disease. And that's something that we see sometimes with viral infections. And in many ways, that's how we've acquired the human genome, is by incorporating different viral genomes and sometimes using them to our advantage, but sometimes to our disadvantage. So looking at some of these studies, and there's a huge amount of studies looking at what are the consequences, and there's new ones coming out every day. So this study looked at the blood vessel damage and inflammation in COVID. So that would be seen in the brain. So some of the brain symptoms were related to vascular damage. And so you do, and we see this also with Bartonella, where there's particularly more of a vascular component. And the COVID was associated with neurological problems, including headaches, delirium, cognitive dysfunction, dizziness, fatigue, loss of smell, and strokes and other neurological problems. So you see more strokes with COVID than we would with Lyme. This was a CDC study looking at some of the more common symptoms. And fatigue is the number one symptom, and that's invariably the most disabling symptom with a lot of these conditions. And a lot of people don't understand fatigue, and they confuse it with everyday exhaustion and say, well, just push yourself. That doesn't work. Fatigue is lack of energy unrestored by rest. And then other studies, and this is a Lambert study, which is expanded on what the post symptoms are. And there they looked at the top 50 symptoms, knowing there were more than 50. And like CDC, fatigue was number one, muscle or body aches, shortness of breath, difficulty breathing. So that's the pulmonary domain. And then trouble concentrating, inability to exercise. But when we compare it, a lot of these are in the neuropsychiatric domain. So looking at, there's fatigue, which is really neuropsychiatric, and difficulty concentrating, that's the brain fog, inability to exercise, difficulty sleeping, anxiety, memory problems. We often call the terrible triad, non-restorative sleep, fatigue, and cognitive impairments. Those are three things that are a package deal. So that if you can improve and get more restorative sleep, then you may see somewhat improvement with fatigue and cognitive functioning. Although Non-restorative sleep may not be the only contributor to fatigue and cognitive impairments, but it's usually a starting point with treatment. And then anxiety, memory problems, depression. And this is a study that was done in the UK, which was 6-month outcomes. So that would be chronic, and it was 236 patients. So a third of them had a neurological or psychiatric diagnosis, such as stroke, intracranial hemorrhage, dementia, psychotic disorders, terrifying hallucinations, coordination problems, memory lapses. Now realize that some of these symptoms may take years to manifest, such as Parkinson's. I expect we're going to see Parkinson's in some of these patients, like we saw with 1918 pandemic, but it didn't manifest the month after the infection. It can develop years later. So people that have been hospitalized are particularly more susceptible to the psychiatric symptoms following the infection. This was an interesting study where they looked at the symptoms in England versus Austria. And they looked at depression, anxiety, and insomnia. And in all three cases, there were 3 times as many people with depression, anxiety, and insomnia in each category in England compared to Austria. How do we explain that? Maybe there was a different strain in the United Kingdom that left a different post-acute symptomatology than we saw with Austria. Who knows? Maybe there's some other explanation. Now, this was a study in America, and what they looked at was that if someone has psychiatric illness, they're more likely to have a more serious case of COVID. And this is looking at 62,000 patients. But if someone has COVID, they're more likely to end up with psychiatric illness. So there's a reciprocal relationship of psychiatry and COVID, that the two can feed on each other, particularly anxiety, insomnia, dementia. And so that seems to be, there's something about it that does it. Now, I think what happens, you get this inflammatory condition, and all these inflammatory conditions increase the likelihood of neurological dysfunction that makes one more prone, anxiety, insomnia, dementia, many different psychiatric syndromes. This was a study looking at 7 months, and this was almost 4,000 patients. Now, this was from 56 different countries, and 96% reported symptoms beyond 90 days, including 10 organ systems. So you're looking at a multi-system illness. So it's not just neurological, not just pulmonary. It's something that affects the whole body. And when you're in an inflammatory state, that affects the whole body. So for instance, when you're in an inflammatory state, even if you don't have infection within the brain, the inflammation in the body, these immune chemicals, the cytokines, chemokines we call them, cross the blood-brain barrier and cause brain symptoms without necessarily having brain infection. That's something that people get confused, that if you have brain symptoms, does that mean you have parasites, viruses, bacteria growing in the brain? No, it can be in the body that still affects the brain. So fatigue was the most frequent. Fatigue, again, 78%, post-exertional malaise. So that's where people have a very low tolerance for exercise, cognitive dysfunction, relapse after exercise, be it physical or mental, intolerance to stress, needing a reduced work schedule, and 22% were disabled as a result of it, which is a big socioeconomic burden, okay? Now, this is another study looking at a systemic review. So there they took all these different studies looking at the post-acute symptoms and added them together, and what came up. So the big things were fatigue, headache, attention span problems, hair loss. That doesn't go over too well with women, but hair loss we see with Lyme, but we see more of it, I think, with the COVID. Difficulty breathing, abnormal chest x-rays, which you see more with the COVID than, you don't really see that much with Lyme, although occasionally you get some pulmonary things, but not usually chest x-ray findings or CAT scan findings. Nor dementia, depression, anxiety, attention disorders, OCD, confusion, vertigo, dizziness, tinnitus. Those popped up along with other physical things. I'm just kind of focusing more on the neuropsychiatric here. Then another study, this is the Graham study, and this just came out yesterday. And this was non-hospitalized. This was out of the Midwest in America. And this was non-hospitalized COVID, what they called long hauler patients. 85% experienced fatigue. And the main neurological findings were brain fog, 81%, headache, numbness and tingling, so that's neuropathy, loss of taste and smell was high, and myalgias, and depression and anxiety was high. All these studies have, and so they're poor attention, poor working memory, and lost productivity, so it really impacts quality of life. You can also see outliers. This is an example of a doctor in New York who acquired COVID, and she was healthy before, and after COVID, she became suicidal and killed herself. There's a number of cases like this where, and I think if you go back to my Lyme suicide article, part of this is the physiology where it shifts your biochemistry that makes a person more suicidal. The other part is the frustration where people around you don't understand it, don't believe you, and you can feel lost. There's those two pieces. This is not the only suicide, but that's an example. This is an article out of the United Kingdom that came out where a pediatrician said, gee, there's all these children that have these ticks, and it's more than I've seen in the past 20 years. And they have the sudden onset of ticks. So their thinking was, well, the lockdown is making them nervous and that's what's causing the ticks. But that doesn't exactly make sense, because it's described as a 13-year-old who was a SARS student, but now there's ticks. She shouts, she swears, she hits, she throws things, she drops her knees, her legs kicks, her arms fly out, she headbutts and smacks herself in the face. So that sounds like a kind of classic autoimmune Tourette's type syndrome that invariably is a post-infection result, often with a PANS or autoimmune piece to it. So how are Lyme and COVID similar? They're both zoonotic global diseases. Both are emerging infectious diseases that we don't have a good handle on. There's some genetic variations and co-infections. Some people get no symptoms or a spectrum of symptoms. It's different from one person to the next. You see this immune piece. You can see a cytokine storm causing multisystem disease. It can be chronic in some. There can be reinfections versus reactivations. It's hard to sort that out. And we use some of the same off-label treatments. And when we try to make progress, we run into the same similar conflict of interest that retard forward progress. This is a reference back to the initial COVID Lambert article, where she looked at identifying what are the post-treatment symptoms. And this was an order of significance. And the yellow is the things that are neuropsychiatric. Now, that's next to the article I did where I looked at 100 Lyme patients. And I looked at that what are the most common symptoms we see in these chronic Lyme patients that I did analysis with. And the number one was poor attention span, brain fog, trouble concentrating, and then joint problems. But if you look at that, the yellow, all these are the neuropsychiatric. Those are the most common. Now, admittedly, since I'm a psychiatrist, maybe more of the neuropsychiatric cases were referred to me. So my sample may be somewhat skewed in that direction, but I think this is fairly representative of late stage Lyme. Low frustration tolerance, easily distracted by frustration, depression, etc. And you do see on the other side, for instance, joint pain is there, but it's lower. It's not 81%. And you do see breathing problems, but it's a different thing. It's air hunger. It's not like the breathing problems you see with COVID. So my hypothesis in working with some COVID patients and Lyme patients, and where it overlaps or sometimes where it doesn't, this is my guess at this point, but I'm open to revise it. If someone has a latent or active case of Lyme tick-borne disease and is not in treatment, and they acquire COVID-19, there may be an exacerbation of their Lyme tick-borne disease symptoms, in addition to the COVID symptoms. That's what I've seen with some of my patients. However, one exception to that is every now and then I see a patient who has a very high fever from the COVID, and high fever seems to help the Lyme disease. Now that goes back to our old theory, and it's what was the first Nobel Prize for psychiatry, where someone gave malaria to treat syphilis and it seemed to have a benefit. Every now and then I've seen someone get an infected port, they get a high fever with sepsis, and then seems to help their Lyme disease. So that's how fever, maybe it boots up the immune system and then it has some activating effect, but that's a minority. I'm not sure about that. I think we have to look for more patients. But in general, people, it seems to reactivate people that were stable with Lyme, and those are the people that were not in active treatment. If, however, someone is in active treatment for Lyme and then they acquire COVID, they often do quite well, and they have a milder case than the other people in the family. And this I've seen with some of my disulfiram patients and people, because many of the Lyme tick-borne disease treatments seem to have a preventative or mitigating effect with COVID. So how do you assess this? And now, like other illnesses, the way you assess something, and this is a tradition of medicine going back to Hippocrates, and Lyme should be no example. You do a screening assessment, a thorough history, a comprehensive exam, what we call review of systems. And for psychiatry, I do a clinical psych exam, mental status exam, neurological exam, and then physical exam relevant to the patient's complaints. And then I combine that with judgment. I look for pattern recognition, and then I look at relevant laboratory testing, and then I try to pull that together. That's how the standard of care is for medicine and in any place in medicine. However, not everybody follows this. Some people do a screening lab test that may be of questionable reliability. And then when it's negative, they say, well, that rules it out, when it really wasn't a test that would be adequate to rule it out. And that's a mistake that we run into a lot. We run into it with Lyme, and we run into it with COVID also, because it's not 100% reliable. A lot of these tests are not that reliable. There's no gold standard. And if you look at lab tests as a gold standard, you're using a fool's gold standard. So I did this article where I looked at 100 patients that were clearly Lyme disease, and I analyzed them. And I said, what's the pattern of symptoms they have? And then from that, I developed a diagnostic system. And I'll share that diagnostic system. I emailed it, and anybody can use it. And I think it may be good actually with COVID too. So that includes the screening questions. Now, these are relevant for Lyme. Then there's a 24-item question that a patient can do themselves. Then there's a more comprehensive, the more common symptoms. And those are the symptoms that I found in 50% or more patients, which was like 60 symptoms. And then there's the more thorough assessment that I do, which is 283 symptoms I look at with 800 data points. That's a full assessment. And then the co-infection screen. So let me go through that to give an idea. So these are the type of screening questions. I'm not going to go through all the details. I don't need to do this, but it's like, are you at risk for Lyme disease? So there's half a dozen questions. Do you do outdoor things? Does your dog have it, Lyme? Do other people in your family? And then these are the common, the more common symptoms, so that a patient can fill out. That's easy for them to understand. So it's a checklist. Now, Dr. Horowitz, Dr. Brascano also have checklists. A number of people have checklists. And you see that on some of the Lyme disease websites. So that's also a good screening test. Then the more common list, I break it down into attention span areas, memory retrieval, processing impairments, executive functioning, emotional symptoms, behavioral symptoms, psychiatric syndromes such as depression, anxiety, fatigue, sleep, sexual functioning, temperature control, those, and then pattern. We also look at neurological symptoms, the headaches, eye problems, tinnitus, neurological symptoms, the irritable bowel, and the pattern of do the symptoms come and go? Do they fluctuate? Do you see Herxheimer reactions? Do antibiotics help? So those are the things that I look at in that exam. Now, this is the more thorough exam. And here I standardized it. I had 4 control groups, and one control group was medical students. Another control group was the patient's pre-infection. Another was the National Comorbidity Study, and another was patients that had other chronic diseases other than Lyme. And to standardize it, when I asked people, well, before you had Lyme, what did you have? And these were my numbers. So for example, 9% had depression before they had Lyme. So I compared that to the National Comorbidity Study. And there they went out in the community, they said, what percent of the population have it? And they found 8.2%. So if you look at the numbers with each category of illness, they're almost exactly the same. So it helps to validate that my pre-infection baseline was accurate. So your average patient that I had 4 symptoms, basically pre-infection, and 82 post-infection. So to break it down, and people that have the other chronic illnesses had an average of 20 symptoms. So attention span problems, troubles. Now, these are in order of significance. So at the top, for instance, 84% of people complained of it, and then we're working our way down to things less common. Trouble sustaining attention, easily distracted, trouble prioritizing attention, hypersensitivity to sound, light, touch, also sensory overload, which is different than attention deficit disorder. A lot of Lyme patients, they get flooded by stimulation. It's too much. They can't screen it out. And it then can be overwhelming and anxiety provoking. Then memory problems, working memory, recent memory, long-term memory is relatively less frequent. Word finding problems, trouble recalling names, numbers, geographical, motor memory, and then dyslexia type symptoms. And this is processing. And processing impairments are what we think of as white matter, whereas other things are gray matter, which is memory content. This is speed of processing. So there's slow processing that people have. So there's trouble with fluency of speech, reading comprehension, spelling errors, calculation, trouble targeting things properly, like walking through doors without bumping on your shoulder on the doorway, and handwriting decline, letter reversals, fluency of speech, etc. Then executive functioning. And executive functioning is the ability to create and sustain goal-directed behavior. So brain fog was number 1 at 84%. And a lot of people say, what's brain fog? And I say, well, take 100 milligrams of Benadryl tomorrow morning and then proceed with your day. And that's what brain fog is. You feel like your head's in molasses. And all these chronic inflammatory things, people have brain fog. It's like your head's in molasses, trouble concentrating, trouble prioritizing, trouble multitasking. And this is compared to your prior baseline. And as you see in the left column there, most people didn't have much. But then other things that I didn't have data on, like intrusive thoughts or time management problems. A lot of Lyme patients, time escapes them, and intrusive thoughts. So imagery is an issue too, where there's these intrusive images that occur. And these can be horrific. That's a good word for it. It's like, where did this come from? It's similar to post-traumatic stress disorder type of intrusiveness. So there can be nightmares, there can be daymares, there can be dreaming while you're still awake. That can be tied to narcolepsy. Illusions, there can be musical hallucinations, there can be auditory visual hallucinations or intrusive images. They could be aggressive or other. And it's like, it makes no sense. It's not something you would choose to think. It would be an image or a thought. One patient described it quite well as frightening, stabbing, horrific images, usually of death, dying, or pain and suffering, often gory and unreal as if in a horror story. Faces with blood or terror, exaggerating an awful expression. Visions of stabbing or killing, often of those close to you or familiar. Episodic, non-continuous. Helpless, stumped bodies. These images don't seem to be associated with a particular occasion, but they come and invade the privacy of my mind. So there's like a true intruder comes to your head with an intrusive symptom. I wrote a journal article about this, and I think this is a very significant thing. And then you can see low frustration tolerance, mood swings, lack of pleasure of life. That ties in with suicidality. Crying spells, paranoia, hyperarousal, hypervigilance. Person just more like tired and wired is a phrase that comes up. depersonalization, derosation, dissociative episodes. So you see decreased performance. The person doesn't perform at school or job or socially. They're reclusive. They drop things out of their hands. They startle more easily, explosive anger, family problems. You see a lot of divorce, marital discord, sometimes domestic violence, accident prone, then suicidal, rarely homicidal, but aggressiveness can be there on a, it happens. I wrote the article on suicide and Lyme disease, and I looked at that, and there's a lot of that, and part of that is the physiology of how it affects the brain. It can make someone suicidal, and there's certain symptoms that increase the risk, such as lack of pleasure of life. But then there's also the feeling of alienation, like no one understands, and a person kind of feels lost and disconnected. And I think it accounts for a lot of suicides per year. But I think, like we hear from the COVID, I think all these infections, these chronic infections, contribute to suicidality. And then other psychiatric syndromes, such as depression, 79%, generalized anxiety, panic attacks. Panic attacks with Lyme disease invariably are long duration. So normal panic attacks are a few minutes, it seems like an eternity. But Lyme panic attacks last longer than a half hour. They can be rolling panic attacks and go on and on. Social anxiety, obsessive compulsive, post-traumatic stress disorder, bipolar sometimes. So these are conditions that weren't there before. And so it worsens whatever you're prone to. It's different with different people. Fatigue and sleep disorders. Now, 76% of my patients had fatigue, and also 76% had non-restorative sleep. There's a strong correlation there. If you have non-restorative sleep, you're more at risk for fatigue. It can be difficulty falling asleep, waking up in the middle of the night, early morning awakening, and then you can sometimes narcolepsy, and you can break it down and looking at what caused it. You can see weight loss early and then weight gain later, emotional overeating. So it affects vegetative symptoms, eating, sleep, sexual functioning, decreased libido, sometimes hypersexuality, just like some people oversleep and some people undersleep. You can see the same, or some people undereat or some people overeat. Some people have hypersexuality and some people have hyposexuality. Then temperature control, that's another vegetative symptom. So there can also be intolerance of cold, intolerance of hot, body temperature fluctuation, night sweats, chills, intolerance heat. Now, low body temperature, that happens with a lot of patients. Skin flushing, low-grade fevers, and then headaches, and there can be a whole symphony of different headaches. There can be complex headaches that have more than one piece. There can be a pressure sensation headache. That's the most common. And then there can be a headache coming from the neck that shoots into the scalp. TMJ type headaches, sinus headaches, migraine, cluster headaches, sexual activity can trigger headaches, and thunderclap headaches, where you feel like you're jabbed by an ice pick all of a sudden. A lot of different eye problems, sensitivity to light, floaters, blurred vision, night blindness, etc. And some of these are less common, but even the less common ones, you have to be aware of and attentive to. Other cranial nerve problems, particularly the tinnitus, the dizziness, and mal d'embarquer, where you feel like you're on a boat, even though you're not, and loss of speech, choking on food, weakness or pain of the neck. The tongue may deviate to the one side, sometimes seizures, more commonly partial seizures. I don't see as many as I used to, but I do see that. And then neuropathy with tingling, numbness, hyperalgesia, crawling sensation, and quite a spectrum of different neurological symptoms. I'm not going to go into all the details. Then you have your musculoskeletal symptoms, migratory joint pain. You can have myalgia, cartilage hurts, deep bone pain, plantar fasciitis, carpal tunnel, etc. Heart problems, racing pulse. You can have POTS, heart goes fast and slow, mitral prolapse, postural orthostatic hypotension, cardiomyopathy, but less than what you see with COVID, right? And then the shortness of breath, Air hunger we particularly see with babesia, and sometimes an exacerbation of asthma. Irritable bowel, nervous stomach sometime, abdominal bloating, sometimes gallbladder disease unrelated to antibiotic treatment, and cyclic vomiting syndrome occasionally. That's a less common thing. Spastic bladder is common. A lot of other symptoms, urinary incontinence sometimes, chronic pain, hair loss, chemical sensitivity, etc. So then symptoms progress and expand over time. They may come and go. Sometimes it's on a monthly cycle. Stress can increase symptoms, and being on antibiotics can exacerbate. That's the pattern. So if we look at now, with this whole COVID pandemic, we already have a shortage in our healthcare system. So this is, and a lot of the people in the healthcare system are burnt out. So we're going to have this pandemic of anxiety, depression, substance use, suicide ideation. Now, some of that is from the economic fallout or the shutdown of society, and some of the direct effect from the infection. A lot of the Lyme treatments help COVID, such as ivermectin. That has been a good treatment. Fluvoxamine is a OCD med that helps COVID. And the same with disulfiram, which is, and there is a lot of research supporting that. Besides hydroxychloroquine, other malaria treatments seem to help. Some of the antibiotics seem to help in some way. Quercetin, vitamin A, B3, C, D, zinc, N-acetylcysteine, methylene blue, anything that improves immune functioning seem to help. So both COVID or Lyme, that's why I think the Lyme patients who are under treatment usually do okay. It's the Lyme patients who are not under treatment that have more difficulty. So Dr. Stricker found that whenever he had Lyme patients on treatment, they did fine. So he said, do prophylactic treatment, but then if you get an oximeter and if you see the oxygen dropping, then you go on an antibiotic, and that seems to help somehow. Even though it's a virus infection, some of these antibiotics seem to help. There's also an increasing, expanding amount of evidence with ivermectin. A good place to look for this is what's called the Eastern Virginia Medical School, EVMS, and they have a website looking at treatment strategies, and they keep updating it. Those are frontline physicians, and I think they're more reliable than CVS, where it's more bureaucrats, where they never treat patients. They look at data, but these are the doctors that deal with this all day long. I have a theory that after World War I, there was a lot of brain damage from all the infections. And then you had a whole generation of brain damaged people, and all those impairments contributed to World War II. When you go in a prison, you have a very high percent of brain injured people. That's how they get in trouble. So are we going to have the pandemic of brain injury so that people are going to be impaired? They're not going to be able to get along as well. And is that going to lay a foundation for conflict in the world? I hope not, but that's a concern as a fallout from this pandemic. And that's a serious concern. So we have to attack the fallout from this as aggressively as we attack developing vaccines. That's the next wave of it. So although there's competition with special interest, a greater recognition of the symptoms of both Lyme and COVID and effective treatment can help prevent needless suffering, disability, death, developmental impairments, learning disabilities, mental illness, suicide, general medical conditions, and economic and non-economic loss. And the hope is that maybe with this this other pandemic, the second pandemic that we're dealing with right now besides Lyme, that may draw attention more to the reality of chronic symptoms related to chronic infections. People may be more attentive to that and hopefully be more able to attack and less likely to slough it off as psychosomatic or some other absurd word. So these are some of the articles that I've done that you can look up, and I think this slide set will be on the web so that you can look at that. Suicide, aggression, my overview article, Lyme disease guidelines, the tale of two pandemics, differentiating psychosomatic, somatopsychic, and multisystem illness, and then our evidence-based definition of chronic Lyme disease from ILADS, and my diagnostic system. And then recently we had a chapter looking at PET imaging of microglia activation that came out of Switzerland in a medical textbook. So, and then there's a number of YouTube videos I've done. We did one here with the Tale of Two Pandemics, and then there's some others. Another thing I've been working on is substance abuse. That's my next project, addiction and substance abuse related to Lyme disease. And The Monster Inside Me is a new movie coming out. It's a documentary. The trailer is available. We're looking forward to the release of that. And so that's basically it. So now, are there any questions, comments, or any discussion?
Thank you very much indeed, Dr. Bransfield. That was just tremendous. Very, very new insights. The foundation for conflict in the world is very frightening, what you just mentioned there at the end as well. I don't know that many people have sort of taken that on board yet as a possible, future perspective. But I will go on to a few questions right away, if that's okay. So one that came in earlier was, you talk a lot about low temperature, chronic low temperature being the reason most Lyme patients don't tolerate neurological medications, especially in higher doses, whereas low doses are often helpful. So the question is twofold. Could you please first of all explain why many Lyme patients do suffer from chronic low temperature in spite of thyroid medication often?
Okay, well, a lot of times we can go back to your high school chemistry class, and many chemical reactions are temperature dependent. And now, but in the body, that's particularly true. And 1 degree temperature change can make a very big difference in how fast temperature reactions occur and how quickly drugs are metabolized. So many people with Lyme have low body temperatures. They may be 97 or 96. And it does a couple things. One is when they have a fever and their baseline, let's say, is 96 or 97, and now they go and they say, well, your temperature is 98, you don't have a fever. They do have a fever because it's above what their baseline is. But the other implication is that because of that low body temperature, drugs are metabolized more slowly. So you often need a lower dose. So you can see someone who maybe has a normal dose, they get Lyme, then they need low doses, and then they're treated effectively, and now they need normal doses again. And to look at it in more detail, you can't just go by the thyroid, because what happens is sometimes you're better giving T3 rather than T4. And a person gets, let's say, a T4 supplement, and T4 is not converted into T3. So T4 is inactive. It has to be converted. So you have reverse T3 that is useless. And a lot of times you have to reboot that. And that person may actually be clinically hypothyroid, even though their thyroid numbers look okay. I think the most reliable test for thyroid is the clinical symptoms, not the lab test, and particularly the basal metabolic temperature. And when the temperature is low, they're still hypothyroid. You haven't corrected thyroid until the temperature gets normal again. So you see this kind of general endocrine shutdown. It can correlate when you're in chronic inflammation. It causes a decrease of delta sleep. That decrease of delta sleep results in decreased growth hormone. Low growth hormone is the master hormone, and all your endocrine system is kind of shut down, the sex hormones, cortisol, and thyroid. So getting that, let's say, more growth hormone and having the T3 corrected, but sometimes you can't totally correct it if you don't have the growth hormone, because that's part of the whole, you have to look at a St. Sebastian diagram and how all these things fit together. And that's always the tough thing with this is, like when I said my average patient has 82 symptoms, how do they fit together? You're not going to treat 82. You're not going to give 82 drugs. How does it fit together? What's the linchpin? And where can you tweak it with the minimal amount of intervention that gets the most benefit? And if you can understand how they fit together and the temperature control that fits with that. So I think you can see that then when people improve, they get the normal body temperature come back up. But when they're low, you often have to start with a fraction of the lowest dose And a lot of people think, well, you don't tolerate psych meds or you don't tolerate a lot of meds. When in fact you do, you just had too big of a dose. Better you give too little initially than too much, especially when there's a low body temperature. Now, another variable can be you have like your P450 system, and some people just genetically have a lower amount. It can be a trait. So that can be a part of it too, but you may have that plus the temperature issue that goes with the chronic illness that we see with these fatigue conditions.
Okay, thank you very much. Another question here. Why do some people get Lyme disease and others who are infected have no symptoms? And equally with COVID, some people are asymptomatic and others get long COVID.
It's a good question. Now, part of it, and this is true with any infection, if there's a meningitis outbreak in a college or a military base, there's somebody who dies and someone who has resistance and someone who gets a mild case. So there's certain susceptibility and vulnerability factors that people have. Some of this is genetic issues, but some of it has to do with prior exposure. Now, and there's probably a very complicated formula there. It may be that if you have other co-infections, so if you have latent Lyme or if you have other infections, and we could see, whether it's Lyme or COVID, same thing. And now there are some genes that we can identify that make some people susceptible. And some genes, for instance, with Lyme, that make people more susceptible to arthritic, autoimmune, or neurological disease. We know that, but it's not just the genes. It's your microbiome that's there that can cause susceptibility. So if the person has a latent case of Lyme and they get COVID, they may have a more serious case of COVID. So then is it the COVID, or is it that it activated the Lyme that maybe you have to be attentive to and treat that also?
Thank you. Very connected with that is, are people who've been successfully treated for Lyme disease in the past more likely to be at risk of getting long COVID? Or is the opposite the case? Like you explained, that patients who are currently in active treatment for Lyme seem to fare better.
Well, I think if they're in current treatment and they get exposed, I think they're better off. But if they've had it and they're doing well, did you eliminate it? Maybe not. It maybe is still there. So I think if you have Lyme, you never know if it's gone. There's no way to know that it's gone. And I think a lot of times, if you've had a significant case, it's probably always there, just like chickenpox or a lot of these things. And then it can reappear later. So and a lot of times you don't draw the connection. So it's okay, Lyme 20 years ago, I was treated, I'm okay now. Now I have all these Lyme-like symptoms. And maybe then something reactivated it. So I think someone has had the prior history and maybe it's still there in a latent form, probably is more susceptible if they get COVID than someone that doesn't have that. But it may be some other infection other than Lyme that might make someone more susceptible. And that may be why someone gets some of these oddball symptoms that you only see with a few people. That it's, and that's, I think that could explain it, that there's some latent co-infection that we're overlooking.
Right, a virus or whatever. Another question here. So many of these symptoms overlap with my own experience of acute insecticide poisoning, which became a chronic condition. Could chemical exposure be a third overlapping condition?
Yes, chemical exposure, chemical sensitivity, toxins, mold, and it's always tricky. What's unique to each one of these illnesses that help you to diagnose it? And people look at that. For instance, they looked at fibromyalgia, chronic fatigue, and Lyme, and they looked at different chemicals with, and they saw an overlap of some of them, but there were some that were unique. Now that's the biochemical signature. But you could also look at the symptoms, like Bartonella. How's Bartonella? More neurological, more the tracts or more pain on the soles of the feet. What's Babesia? And it's very tricky, what's unique. And there isn't that much that's totally unique to any one of these diseases. And that's what makes it hard. And you're looking at the pattern, and the unique symptoms are the giveaway, like the bullseye rash. What's unique to Lyme? The bullseye rash or the acrodermatitis chronic hemotrophicaans. But how many people get that? Not a lot of people. But that's unique to Lyme. And all the others, just like chest pain. What does chest pain mean? It could be a lot of things. It doesn't mean heart attack necessarily. And that's how we make a diagnosis in medicine, is symptom pattern. And progression of disease over time, that also helps us. Like, how did it progress over time is a giveaway, not just what the current symptoms are.
Right. Thank you. You've already mentioned in your talk how some of the manifestations of long COVID appear to be very similar to pandas. In other words, an autoimmune attack on neuronal tissue. A question here: how might you convince psychiatrists dealing with a pandas situation that this is infection driven? This is something we have particular difficulty with here in Britain, and I know in much of the States too. Still.
Well, one is read the medical literature, and the other is if it's a doctor that wants to know more, give me their name and I'll put them on my medical education group for doctors who want to learn
fantastic.
more. And that's something I've been doing for over 20 years. And we have 750 in that group who are interested in learning more. Now, like when you get something that provokes the immune system, and chemical exposure, mold, or some of these things, deficiency, toxicity, infection, allergies, they can provoke the immune system. Now, some of that can be that Th1 or Th2 reaction. So it could be inflammatory, it can be autoimmune. So the pandas usually has more of an abrupt onset with more of that autoimmune type of symptoms, or a different symptom cluster. And that's more of a sawtooth pattern where boom, there's an abrupt onset and then it gradually drops off. Whereas the inflammatory things are more gradual, that come and go more in waves. But you can get both of those with these as a follow-up of these infections, depending on how it provokes the immune system. Many of the symptoms are from how the immune system is provoked, but some are the direct effect of how the infection affects the body or harms the body in some way. And sometimes that's the giveaway of how you can differentiate it, because many things provoke the immune system in a very similar way, but the direct effects may be somewhat unique, and that can help differentiate what's the culprit here that we're dealing with.
Yeah, thank you. Linking up psychiatrists here to your forum, your educational, which is entirely free of charge, isn't it? And it's
yes, yeah.
Regular exchange would be a very good idea.
The way that got started is a group of us met. I organized a luncheon at one of the American Psychiatric Association meetings. And I said, listen, we're all seeing, I think, the same thing. And we're all in different areas. And how can we kind of work together and exchange this? Because maybe we could learn from each other and do some cooperative effort. So we said, well, we need more than one luncheon to kind of sit and get this organized. And that was in 1999 or so. And so then we said, well, let's do a list and we'll share things. And then the list got bigger, and then we made it a listserv, so that, we share research, we share ideas and questions. And a lot of us struggle with the same things. And admittedly, maybe there's a little different strain in Australia or Europe or America, but it's pretty much the same thing. And it's pretty much the same issues of how people have trouble grasping and understanding it. They can't connect the dots, and we have to connect the dots.
Yeah, absolutely. Thank you. Do we know much about why sleep is so affected in someone with both continuing chronic COVID and Lyme? And what can we advise someone who feels like their body has become nocturnal, or as if their immune system just won't allow the body to sleep?
Well, one reason why some people get nocturnal is they get the sensory overload, and it's easier to be up at night when you don't have all that sensory input and you can hear yourself think. But it's also can be an effect on the brain where it alters your circadian rhythm. But sleep is when the body repairs, deep sleep. When you fall asleep, you sleep in cycles. You have deep sleep and then your REM sleep, and that's more memory reorganization and emotional recovery. But deep sleep is where you take the garbage out of your nervous system and get rid of it. The interstitial space between nerve cells expands and it eliminates. And lack of sleep correlates with a greater risk for developing Alzheimer's and everything. So deep sleep is what cures you and repairs you. The body is designed more for cyclic activity and recovery. So if you don't allow that cyclic recovery to occur, a person has trouble improving. So sleep is critical, and in many ways, and it also helps your immune system to be more active. That a part of that, what I was talking about, growth hormone, it also boosts adaptive immunity. So you get early inflammation and then later adaptive immunity, and sleep helps that. So in many ways, sleep activating the immune system does a better job than I could ever do by trying to figure out what to tweak. Okay. We could give this antibiotic, or we could give that psych med, or treat that symptom. Your immune system does a better job than I can by figuring it out. So just improve good sleep. Now, a problem can be if you're a stoic person and you push, and drive, and don't allow yourself to rest and recoup, then that's puts you in a tailspin and it's hard to ever recover. That used to be the strategy of saying that's how to treat chronic fatigue. And it really was a complete disaster. You don't want to do that. We call it sickness syndrome versus stress syndrome. So stress syndrome is where I'm in a war zone and I have to fight for my life, whereas sickness syndrome is I got sick yesterday, I just want to curl up in a ball and do nothing and let my body recover. We have to respect that and let it happen, and that helps us to recover and not fight it. But often there's sleep inefficiency for various reasons. Like if you have restless leg or nightmares, then it's hard. So you have to address what interferes with it, allow a person to get the restorative sleep. So most commonly when I treat symptoms, I'm treating improving the quality and the efficiency of sleep, and also improving whatever symptoms stresses a person out and prevents. Those two things are usually what I attack the most. And that's, if you treat those symptoms, then your immune system gets stronger. You don't have energy diverted away towards something else, and then a person may heal better.
Yeah, thank you. There is a specific question related to that that's come in, which is how can we actually help our clients deal with that sensory overload? Is it, do you tend to use the neuropsychiatric medications, or is it more lifestyle, or
Well, I think it's both. It's not the same as attention deficit disorder, because attention deficit disorder is distractibility. This is unique. This is almost like what you see sometimes with autistic children, where they get the sensory overload. And and if you do brain imaging, you see that the thalamus is overactive. It doesn't gate sensory input the way it normally would. And that's the problem. So you have to kind of realize that you're better in low sensory environments, and a lot of times wearing hats with a brim sometimes with the light, or the sunglasses, or being in a lower stimulation environment, and recognizing that now the ADHD meds, the stimulants, or the Nuvigil or armodafinil, things that help focus, help to some degree, in that a person's able to focus, but they still can get flooded. And I think it's generally the general treatments that help it. Sometimes processing speed, memantine helps that, but that's a little different. That's not the sensory overload. So it's a tough symptom. And then that leads to the hyperarousal, and then the hyperarousal makes it hard to shut down. It's hard to sleep. That's how do these symptoms fit together? How can we untangle this ball of string and break free of the vicious cycle of disease that is self-perpetuating sometimes?
Thank you. Just to mention, by the way, that quite a few questions have come in relating to vaccines, and we did make the agreement earlier. In fact, we will be doing so with all our speakers at the moment, that because it's all so new and the vaccines are, certainly in America, very clearly labeled as being experimental, not necessarily here in the UK, even though they are the same vaccines, but we just feel that more time is needed. So it would be very, very hard for Dr. Bransfield to honestly say what his opinion was on, for example, Lyme patients taking the COVID vaccine or whatever. So hopefully we'll have you back later, Dr. Bransfield, again, and we can perhaps go into questions of that kind when there's further information that's come in. But I think that because it's already 5 past, we do have quite a few further questions that have come in. but I think it would probably take us a bit beyond time to try and answer further ones now. So we'll save them for the next time we have
Okay.
you.
All right, Joanne. Okay.
So huge thanks. Hopefully we'll be sort of over the worst of this particular period soon, so that we can travel and we'll see each other and meet in person again. But is your feeling that this is going to continue for a very long time right now, from your perspective there in the States?
I think this is going to fizzle out some in increments and waves to some degree. I'm in New Jersey, that has the highest death rate per million of any state in the United States, and any country in the world except for Gibraltar, that's pretty close to it, at 2,700 per million. And I see the numbers dropping. I think that there's more herd immunity. Some people are just resistant to it. And I don't see the death rate day to day at the local hospitals as bad as it was. So I think we're going to slowly come out of it, but I think it's going to be a long time. And I think it's going to leave a very strong impact on how we go about things, just like 9/11 did with airplane flying. And I think it's going to make us more conscious of the role of infectious disease and how that affects health. And I think then other countries that have less access to technology, that's going to be an issue. And it's really the same as the Lyme controversy, where you're looking at these bureaucratic, distant researchers with number crunching in administrative academic positions and how they interpret the literature versus the frontline doctors that deal with it day in and day out with a long-term responsibility. And we have to cooperate between these two groups in an effective way, instead of a power struggle or a competition between the two groups. Mm-hmm. And that happened, that was an issue with Lyme disease, and I see it as an issue with COVID, and I hope we don't get stuck there. I hope it's a more cooperative effort that will evolve towards, and a more cooperative global effort. The world has a common enemy today. A lot of times there's situations where other countries are the enemy, but we all have the same enemy. And hopefully we work together with that, would this lead to more global cooperation? Who knows?
Yes, what you did mention earlier was that possibly because there are COVID sort of centers, long COVID clinics,
yes,
popping up all over, that possibly this will in the end mean that both chronic Lyme patients and also ME patients do get better treatment. Do you think there's that possibility?
My hope is, maybe Lyme patients can kind of slide in through the back door of these COVID centers saying, well, maybe it is COVID, but it's a different manifestation. But it's amazing how, you realize how hard we try to get these clinics set up, or we try to get a hospital unit for Lyme patients, and we can never get it funded. Yeah. And same with the chronic fatigue, and now you see it pop up so easy, but it has to do with there's people that want to put money into it with this, whereas they never did with Lyme. So will that spill over, or will there be competition and will it take money away from Lyme? I hope it doesn't take money away, but I hope it expands our perception and our definition of these conditions, particularly if they're maybe lumped together in the same pot somehow. Right.
Yeah, absolutely. That would be tremendous. Well, thank you very, very much indeed. That was very, very eye-opening. I would just like to mention that we do have another talk in our long COVID series on the 7th of April. That's Wednesday after Easter. That'll be Dr. Craig Shimazaki from Oklahoma, from the Molecular Laboratory, and he'll be talking about long COVID, a post-infectious autoimmune syndrome, understanding commonalities and biological clues from other post-infectious autoimmune syndromes. So that will be, I think, very interesting as well. And we will have another speaker, but I very much hope to have you again, Dr. Bransfield.
Okay, thank you. Have a good night. I hope to see you in London soon.
Absolutely,
okay?
Yes.
Yeah, everybody wants to get back to traveling like we always used to do.
Yeah.
We're tired of being locked in our house this way, and although maybe it's good, it helps us to develop Zoom more, these meetings. Right?
Yeah, thank you. Okay, thank you very, very much indeed.
Okay, bye.